Good morning. Welcome to the Chronic Kidney Management in Service presented by Faith Allen. Today is March 29th, 2022, and I'm going to turn it over to Faith.
Thank you, Dr. Baldwin. Again, as Dr. Baldwin mentioned, my name is Faith Allen. I am a PharmD candidate at Campbell University College of Pharmacy and Health Sciences. Today, my presentation is entitled Chronic Kidney Management. By the end of this presentation, you will be able to describe the epidemiology, pathophysiology, and presentation for patients with chronic kidney disease. And we will review guideline recommendations regarding strategies for chronic kidney management and assess some non-pharmacological therapies for patients with chronic kidney disease. In the United States, 30 million adults have chronic kidney disease. If we think about it, that is more than about 1 in 7 adults. The highest risks are unfortunately African Americans, Hispanics, American Indians, and Asians. And the common causes are due to diabetes and hypertension. So it's very important to control your blood glucose and blood pressure, which will help prevent renal damage and delay progression to end-stage renal disease. So before we delve into the definitions, let's just briefly go over what the kidney is made up of. So in our picture, we see the kidney on the left. And if we magnify this kidney, we have the nephron. And we know the nephron to be the functional unit of the kidney. Its primary function is to control the concentration of sodium in water. And with these nephrons, they reabsorb what is needed back into the blood, and the remainder is then excreted into the urine. This is a key player because it regulates our blood volume and in turn our blood pressure. So the major components of the nephron are the Bowman's capsule, which is this circle here, and the glomerulus, the proximal tubule, the loop of Henle here, and the distal convoluted tubule, and then the collecting duct. And the nephron has about 1 million nephrons in the kidney, which is a lot. So that is why the kidney is definitely essential. So what is CKD? CKD can be defined as a progressive loss of kidney function over months or even years. And it's assessed by the degree of kidney function is assessed and measured by the glomerular filtration rate, which is denoted by GFR, or the creatinine clearance. And these measurements are typically used clinically to gauge the kidney impairment and in order for practitioners to follow the course of the disease and assess the patient's response to therapy. GFR particularly is used for staging of kidney disease and for dosing of certain medications. And creatinine clearance is typically used by pharmacists to calculate for patients to make sure we avoid contraindications and dosings adjustments. And we'll get into the GFR staging in the next slide. So the stages of kidney disease, there are 5 stages of kidney disease. And the KDIGO guidelines, which is the Kidney Disease Improvement Global Outcomes, recommend using GFR and also albuminuria, which is the level of albumin which is present in the urine, along with the cause of CKD, to basically determine the degree or stage of the patient's renal impairment. So stage 1 is normal function. There could be kidney damage in this stage, but the normal function has been maintained. That is why the condition can go unnoticed. It can actually go unnoticed for a considerably amount of time, because in this stage, there are not many symptoms. So going into stage 2, this is considered a mild loss of function. So within this stage, we begin to see a very small loss in kidney function. The patient may notice mild symptoms such as fluid retention and high blood pressure. And then on to stage 3, which is considered a moderate loss of function. In stage 3, the stages are split up into 2. So it is considered 3A and 3B. And on your handouts, I actually listed the numerical number for the GFR of the stages in each category. But in stage 3 here, we see mild to moderate loss of kidney function with more severe symptoms such as back pain and fatigue. And then that brings us to stage 4, which is considered a severe loss of function, where we will see symptoms such as anemia and bone disease. And then stage 5, which is the last stage, is basically kidney failure. In this stage, the kidney function is either close to breaking down or has lost completely. And patients at this stage will need dialysis to get rid of the toxins and will suffer from symptoms such as shortness of breath, and also nausea and vomiting. So we spoke about the stages of kidney disease, and now we'll delve into the renal replacement therapy for patients that are in stage 5. So there are 2 types of renal replacement therapies, hemodialysis and peritoneal dialysis. So as CKD progresses to failure, which will be that stage 5 disease, dialysis would be required in all patients who do not want to receive a kidney transplant. And the difference between the 2 are that for hemodialysis, the patient typically will go into a dialysis center, and it's typically about a 3 to 4 hour process. And they'll typically go several days a week. I know a lot of patients go like a Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday. And basically, in hemodialysis, the patient's blood is pumped into this dialyzer, which is the dialysis machine, and then it'll run through a semi-permeable dialysis filter. In that filter, it encompasses like a concentration gradient that would then remove the waste in like products, electrolytes, and the excess fluid. And then in contrast to peritoneal dialysis, it's typically just like a dialysis solution that the patient has, indicated by the picture on the right, and it has glucose, and it's pumped through the peritoneal cavity, which is the abdominal cavity that is surrounding the organs. And then the peritoneal membrane serves as a semi-permeable membrane, which again, in like the HD hemodialysis, is like the dialyzer. And then that solution is then left in the abdomen to dwell for a significant period of time, and then it's drained. And then that cycle is repeated throughout the day, every day. And peritoneal dialysis is typically performed by the patient at home. Hemodialysis can also be performed by the patient at home, but it's typically done more frequently So like within the dialysis center, I mentioned that the patients typically go 3 times a week, but if they decide to do HD at home, they'll typically do it 5 to 6 times a week. And just thinking about the amount of time that a patient is spending, it could be very complex and affect that patient's quality of life. I know my grandmother had severe kidney disease, and she opted not to do dialysis. So she ended up dying because she just didn't want to go through going back and forth to dialysis. So this is typically, you know, a process that patients will have to consent to doing if they want to prolong the life of their kidney. So we'll now delve into chronic kidney management. So when we think about chronic kidney management for these patients, the general management of patients with chronic kidney issues involve these 4 key players. So the treatment of reversible causes of kidney failure has to be done by slowing or preventing the progression of kidney disease, adjusting drug doses when appropriate, treatment of complications of kidney failure, and also identifying and preparing patients who will actually benefit from renal replacement therapy. So either the HD or PD. So if we want to reverse the cause of kidney failure, we need to understand what would be exacerbating their original cause of kidney disease. Because patients with CKD with a recent decrease in kidney function could be suffering from an underlying reversible process. So if it's identified and then corrected, that can also result in the recovery of their kidney function. Also, the complications of the treatment failure could be decreased renal perfusion. So if the patient, you know, is experiencing hypovolemia, which would be by vomiting or having diarrhea or using like excessive diuretics, or maybe even bleeding or hypotension, we want to make sure that we have these issues in order for their kidney function to be maintained. And also drug doses. I did not include a list because there is a very long list of drugs that need reductions, but just to name a few that could adversely affect kidney function or worsen kidney function. There are common offenders such as aminoglycoside antibiotics if the patient has been hospitalized, and something that is readily available that could adversely affect the kidney would be NSAIDs. So our over-the-counter ibuprofen, aspirins, things of that nature should basically be used with caution in patients with underlying CKD. So when we think about the kidney, as we age, we have to think about several different factors that could play into our management of our kidney function. So I just spoke about the nephrotoxic drugs. Again, medications that patients take on a daily regimen, drug interactions. Also, dehydration is a huge player. We spoke about that nephron and how it is electrolytes are changed and they're reabsorbed. So not having the right amount of electrolytes can lead to dehydration and decreased perfusion for the kidney, which can lead to damage. So as we know, there's a high incidence of the elderly in the United States. So already the elderly is predisposed because they have changes due to absorption, protein binding, volume of distribution, and clearance. And also several key disease states such as cardiovascular disease, hypertension, diabetes, tobacco use, and a high protein diet also can add to the stress on the kidneys. So a modification of drug therapy, I wanted to just highlight a little bit further. I noticed that the adverse drug reactions was 3 to 10 times higher in those in patients with CKD compared to those without. So in this case, pharmacists are huge players in making sure that we are doing these drug-drug interactions checks, and we're appropriately monitoring our patients' medications, especially those with CKD. And as we know, the drugs that we take are in the actual metabolites are excreted by the kidneys. And few medications are studied in elderly and the CKD populations. So it's good, again, for pharmacists to make sure that we are staying on top of patients' medications use. So these are just some non-pharm ways to make sure that we keep our kidneys healthy. We always, I guess the number one player would be actually to stay active, stay fit. It's gonna overall reduce our blood pressure, and it's gonna help us maintain a healthy weight. It will particularly also help control our blood sugar levels, particularly in our diabetic and our obese patients. There are various ways to do this now with, certain diets. One is really popular, intermittent fasting. And then actively monitoring our blood pressure, and use approaches such as exercise and having a better diet to basically bring our blood pressure down. Again, we always want to put emphasis on eating healthy, eating a balanced diet, and making sure that we're drinking lots of fluids. We want to always make sure that we avoid smoking, and we're limiting alcohol consumption. And additionally, we do want to, reduce the amount of pain medications, painkillers, which could put stress on our kidneys, and have your kidney function test regularly if we are at risk. It's important if we have CKD or any type of kidney issues, that we're staying in communication with our pharmacists, we're staying in communication with our physicians in order to avoid any potential damage. And lastly, World Kidney Day. World Kidney Day was on March, this year it's already passed, it was on March the 10th. But this is a time, and it happens every year in March. So I just invite everyone to, I guess for next year, to, just come together and celebrate World Kidney Day, and to help advance the education. And it's just basically a small token to remind supporters of the primary function of their kidneys and their location in their bodies. And this ends my presentation. Here are my references. I also have a handout that will also, that accompanies this presentation. And if you guys have any questions, I will be happy to send out my email or set up a Zoom to go over the handout as well. Thank you so much for attending.
Hey, I have a couple questions, and they might as well. Why did what was the reasoning, because I may have missed it, for changing it from just calling it chronic kidney disease to chronic kidney kidney management?
I think chronic kidney disease is what is used to label like the different functions throughout the kidney. And I think chronic kidney management is the huge umbrella term that encompasses like the lifestyle changes in the pharmacological management. So I guess it could be interchanged, if that makes sense.
It does. I think you're correct. I think it is a management. The use of the word management changes the general public's perception of it versus chronic kidney disease. Why, for those that may listen later, why do they look at how much albumin you have in your urine if you are looking at kidney health?
Okay, so if we think about albumin is the primary protein that is measured like in the urine to assess kidney disease. So then the albuminuria is usually like referred to proteinuria. So it's just that breakdown that we see in the urine.
I cannot think of any others. So thank you for who all will watch this later. If you've got any questions, please reach out to me or I will put you in touch with Faith if needed. Thank you.